My name is Kevin Gassemi, and I'm part of the Center for Esophageal Disorders here at UCLA. And it's my pleasure to introduce our first speaker, Dinesh Chhetri, who's part of the Department of ENT. He's going to be talking about a topic today that is quite common and quite frustrating for both ENT physicians and gastroenterologists. Dr. Chhetri is the director of the Swallowing Disorders program at UCLA and also the co-director of the Laryngeal Disorders program. And I'll ask him to entertain us. Thank you very much.
Thanks, Kevin. Welcome to the foregut. I want to remind all of you guys that the foregut does start at the mouth, so thanks for inviting me to give this talk. I'm going to talk about Laryngo-Pharyngeal Reflux, my viewpoint on this topic, formerly known as atypical and extraesophageal issues in GIRD. Get that ENT guy off my back. So I know this is a very somewhat controversial topic. And just with a show of hands, I want to know how many people believe that LPR as a disease entity exists? How many? So very few. Excellent. And how many think it doesn't exist? Okay, actually nobody's raising their hand, so who knows? 50-50, I would say, and that's really, really appropriate. So reflux, as you guys know, it's backflow, and GIRD is backflow of reflux contents from the stomach to the esophagus, and LPR is backflow of the stomach contents to the throat. So we're talking about refluxing it all the way above the US barrier into the larynx and the hypopharynx, also known as extraesophageal reflux, reflux laryngitis, atypical GIRD. So when I was asked, I thought, okay, let's talk a little bit about how did we get to this point of wondering how to deal with LPR. The problem has always been that in our field, we've been dealing somewhat in a frustrated manner with these symptoms. So a patient comes to you with a symptom of globus sensation, or chronic cough with no apparent cause, chronic throat clearing, hoarseness, dysphagia symptoms, no obvious abnormalities on esophagram, let's say. Postnasal drip, what is that? I've never seen one of those, but we talk about it all the time. And sticky mucus in the larynx. So if you look at this picture over there, there's some sticky mucus in the larynx. This pointer's not going to work. Okay, so here we go. So there's some redness in the back part of the larynx here, some sticky mucus. You can also see that there's some swelling in the infraglottic area, and let's say this patient complains of globus. What is causing this patient's symptoms? So the really question is, what proportion of these symptoms that we see in our office is attributable to LPR? The other thing to remember as a background is, for the longest time, 30, 40 years, we've been saying that pretty much everything from the nose to the lungs can be attributable to reflux, anything from subglottic stenosis to carcinoma to adenoiditis, middle ear effusion, everything there is a paper on saying that reflux is somehow associated with it. So that's made us quite confused. And in all of these cases, although we have been able to show associations, we've never been able to show a direct causality. So I thought I'd just talk about how did we get here. So in that background, there was a paper written in 1991 by Jamie Kaufman. It was his trialogic thesis, the otolaryngologic manifestation of gastroesophageal reflux disease, looking at 225 patients doing dual pH probe studies, so upper probe at the just above the UES and lower probe above the LES. And what this paper basically talked about was that if you looked at all these conditions, that there's a lot of, the incidence of GIRD is quite high in this patient population. The interesting thing to me is if you look down here at dysphagia, globus, cough, actually the actual incidence is not that high as some of the other conditions. Subsequently, there was a paper written looking at 113 consecutive patients seen in a laryngology clinic with throat complaints. And again, a dual probe pH study was done. And the definition of abnormality in these studies was a single pharyngeal event immediately preceded by a sudden drop in the esophageal probe of equal pH magnitude. And again, if you look, it's a little busy, but on the right you can see that there is a high prevalence of LPR based on that criteria. up to 73% of patients walking into the clinic had LPR. Well, nobody really thought about the fact that if, it seems to me if you have such a low bar for what LPR is, you're going to get a very high number for abnormal pH studies for the upper probe. I have to tell you, does LPR occur? Yes, I think you will know when you take a big meal and you're sitting on your couch, you feel all that gastric contents come all the way to your throat. You know that LPR does exist, but the really question is, what is the consequence of that? What is the consequence of a single reflux episode to the laryngopharynx per 24 hours? What is the evidence? And that is really what we're struggling with. Having said that, we did have a position statement from the Academy of Otolaryngology in 2002, basically saying LPR is different from GIRD, and these are the things that we said. Patients with LPR do not have esophagitis or heartburn. Patients with LPR are upright refluxers compared to GIRD patients who are supine refluxers or nocturnal. Patients with LPR have urea symptoms. GIRD has ileus dysfunction. Patients with LPR need more aggressive and prolonged treatment. So we're talking about treating BID with PPIs over 6 months, and that the pathophysiologic mechanisms in LPR is different from GIRD. So what is the pathophysiologic mechanism for LPR? And so for that, a number of things have been proposed. The first is that there is a direct injury to the larynx by acid or pepsin. The second thought was, well, you get the acid in the throat, but then it then causes you to have chronic cough, throat clearing, which then leads to trauma to the larynx, and then you have all the symptoms and signs. Or possibly you have the reflux all the way to the throat, but you need an additional etiology, such as a concurrent viral infection or voice abuse, and then together in a synergistic manner, you develop the symptoms and signs of LPR. And the idea was that the larynx is more sensitive to refluxates than the esophagus, and that the larynx lacks many intrinsic defense mechanisms present in the esophagus. And that's really true. If you actually look at lots of basic science studies that I won't go over today, there is some evidence that there is a lack of defense mechanisms in the larynx compared to the esophagus. But that also makes us a bit more confused as we talk about this. So what are the symptoms of LPR? So typically what we thought about is hoarseness. And when I say hoarseness, it's, patients comes to you and says, I feel hoarse, but when you listen perceptually, they sound actually quite fine to you. If you can hear a change in somebody's voice, and if you as a clinician can say, your voice, there's a change in it, I can assure you 100% I will find a different cause than LPR. But we're talking about patients who come and say, I'm hoarse, and you listen and you go, well, you don't sound so bad. So clearing the throat, excessive mucus in the throat, difficulty swallowing, also subjective kind of swallowing difficulty as opposed to a definitive change on a swallow examination. Breathing difficulty, choking episodes, laryngospasm, troublesome or annoying cough, globus, as we talked about, and also obviously, associated with esophageal symptoms, heartburn, chest pain, etc. Okay. So they actually had a study looking at this. This is actually, to me, a very interesting study that sort of validated this reflux symptom index. These guys took 25 patients with their clinical diagnosis of LPR and a 24-hour pH monitoring, as we discussed before, and they administered this reflux symptom index and a voice handicap index. And the treatment was behavioral modification as well as BID PPI. You've got to remember, this is really interesting that they added behavioral modification as part of their treatment of LPR in this case, because later on when we talk about the placebo effect in this population, this will become more clear. But they were then showed that with treatment that the RSI in fact went down, and therefore they said this was validated. What are the signs of LPR? And these are the things that have been discussed. So on the left upper hand corner, you can see a larynx. Let me see if I can use this. So this is actually what we would call a subglottic edema. This is also known as a pseudosulcus. You can see a little divot in the vocal fold here, and that basically is because there is some swelling of the infraglottic area, just the inferior portion of the vocal fold. Here you can see different amounts of edema of the larynx from just a little bit of edema over here where it says C to a significant amount of a polypoid chorditis or significant swelling of the vocal folds. The other signs that we talk about are just erythema of the larynx. This area where between the vocal cords, the interarytenoid area, pachydermal laryngeus, that's supposed to be also quite sensitive. And there are lots of studies saying, you know, this is how you diagnose reflux. The problem is many of the studies, when the patients are treated for LPR, these signs do not change significantly. So there's a lot of questions in our field about the actual validity of the reflux finding score as well. So then the next question is, you know, so is it just the light? That's another big question being posed in the field. And here on the left side, if you look at the larynx, this is seen under stroboscopic light. The larynx looks a little bit red, and there is more redness in the back part of the larynx than in the picture on the right, which is just looked at under halogen light in the clinic. And you can see that some of the redness, in fact, most of the redness looks like it's gone. And you know, another interesting observation is when I take patients to the operating room and I look at the larynx, I don't ever say, oh, wow, look at that. There's so much laryngo-pharyngeal reflux here. The problem is we don't have the same correlate like a Barrett's change in the esophagus in the larynx. So that also adds to the confusion of diagnosing LPR. So let's say LPR is caused by acid. Does PPI work for LPR? So this is an often quoted study by Stewart et al. It was a randomized placebo-controlled trial with 42 subjects. And they did a baseline pH study and treated with PPI. So the outcome measured was basically reflux symptom questionnaire, as well as the proportion of subjects noting global improvement. They also instituted a lifestyle modification and followed up in 2 months. So this was the conclusion. 53% of PPI-treated patients and 50% of control-treated patients noted significant global improvement. No patients reported symptoms being worse. And the results of this study suggested that lifestyle modification for 2 months, with or without PPI therapy, significantly improved the symptoms of chronic laryngopharyngitis when compared to pre-treatment baseline. And then there are lots of studies have been done. This one in 2001, another prospective placebo-controlled randomized double-blinded trial, 24-hour pH monitoring, 30 patients, 40 milligrams omeprazole BID versus control, and both groups improved significantly. And they did find that hoarseness and throat clearing improved more than in the treatment group. The laryngoscopic signs did not improve. And then lots more. Lansoprazole, 30 milligrams BID. This one showed by Elsrog, 50% versus 10% improvement. The one by Havas, 30 milligrams Q-day versus placebo, no improvement in symptoms. Pantoprazole, 40 milligrams BID versus placebo, no significant difference. And then esomeprazole, 40 milligrams BID, no improvement in symptoms. So there's probably, at least based on randomized prospective placebo-controlled trial, there's not a significant evidence that PPI really works for LPR. So one of the other interesting observations is, to me, is that I do notice that in patients who have GI symptoms, meaning the esophageal symptoms of GIRD, and they have associated throat symptoms, they do tend to improve on PPI therapy. That makes sense. So there's some kind of link between the lower esophagus and what we're feeling in the throat. So why is LPR such a mess? Why can't prospective studies show that PPIs work? And what is really the nature of the placebo effect? We just don't know. There's also some thought that maybe there are some reflexes from the larynx to the lower esophagus. Does that have any bearing on some of these symptoms that our patients are feeling? So we said, well, maybe it's not acid, maybe it's pepsin. So that's the new thing. Is pepsin the real culprit? So as you guys know, pepsin is maximally active at pH of 2, but complete inactivation does not occur until pH of 6.8. And it can even remain stable until pH of 8.0 until it's irreversibly inactivated. The mean pH in the laryngopharynx is 6.8, so pepsin could lay dormant until activated by acid. And studies have been done showing that the laryngeal epithelial cells exposed to pepsin can take up pepsin, and then pepsin can then cause mitochondrial Golgi damage. Studies have also shown that bile-induced laryngitis does exist in a rat model. So the next phase that we're dealing with is maybe it's the pepsin, and maybe a saliva test for pepsin is the next answer. And again, studies have, if you look, you'll find studies pretty much supporting anything. This one by Johnston demonstrating that, that intracellular pepsin damage, pepsin was seen in 8 of 9 patients with LPR. And in their group, or the control patients did not have any intracellular pepsin. And other studies looking at pepsin and laryngeal injury, Vasey in 2004, concluding that pepsin alone or with bile acids can result in mucosal injury, but only at an acidic pH. And then Johnston again showing that pepsin is actively uptaken in the laryngeal epithelial receptors, and that maybe there is some kind of blockade that can be instituted to prevent pepsin damage. But this is still a very much a confusing area, because what we don't know is how much pepsin do you need at what pH to lead to a clinically significant symptom. So again, there's a lot of unanswered questions in this field. Okay, so if we say, okay, maybe it's not acid, maybe it's not pepsin, well, let's figure something else out. Maybe it's reflex. Maybe it's we can actually keep it as LPR, because it's Laryngo-Pharyngeal Reflex, not Laryngo-Pharyngeal Reflux. And the idea is that acid in the distal esophagus can cause some vagally mediated reflex that leads to the extraesophageal symptoms, coughing, laryngospasm, bronchospasm. But what we don't know is, what is it that exactly mean? Is it a lowering of the reflux threshold, and so the patients are more sensitive to whatever it is that's inciting the symptoms? And what is the anatomic level of this abnormality? If it's an abnormality of reflex, where is the reflex arc being affected? And if we don't understand that, then we really don't know where to then institute some kind of treatment. And if it is a reflex problem, is the damage ultimately reversible, and how do we do it? So still, if you look, you'll find studies in this too. So Tokashiki, 2010, they exposed acid in the distal esophagus. 13 of the 20 subjects reported globus when acid was exposed to the distal esophagus. Chen in 2009 took globus patients and did lower esophageal distension, and 7 of the 9 patients with globus referred the sensation to an area above the sternal notch. And then another study in 2008 looking at patients who had pre-existing GIRD with cough, and then that their sensitivity to experimental capsaicin exposure was heightened by esophageal acidification. So there are studies also looking and saying, it could all be related to some kind of abnormality of reflex. So we've kind of gotten to a point where we see a lot of patients who have the symptoms that we described, and we've given them PPI, and it doesn't work. And we look at the larynx, and we really don't see much. So what do we do next? So the pendulum is kind of swinging back. I think we went to a point where we would be liberal about diagnosing LPR, and now we're going back to looking much more closely at what is happening at the larynx. And so this study from New York looked at more than 20 patients who were referred to the voice center with a diagnosis of LPR and been placed on PPI. And when they actually started looking at the larynx, they found a variety of conditions that could explain their symptoms. So they found things like benign lesions, even neoplastic lesions, paresis, paralysis, vocal fold scar, muscle tension dysphonia. So in other words, there are explanations for these symptoms when one looks very closely. And I can tell you, much of the time when there is something going on, when you look closely, what you'll often see is some kind of weakness of the larynx or some kind of scarring of the larynx that's causing some of the hoarseness symptoms. Another study kind of concluding the same thing. This one looked at 26 patients referred to the voice center with diagnosis of LPR, placed on PPI, and when looked very carefully, their conclusion was that many of these conditions could be explained by the presence of a voice disorder or presbylarynx, sulcus, or paresis. So the conclusion is that I think LPR is being overdiagnosed if we just kind of tell, whenever somebody comes and says, I'm clearing my throat and my voice is hoarse, I feel something weird, and say, okay, it's all LPR and give PPI, well, we're going to overdiagnose. And so any of these studies we do are going to have a very low power because we're not really diagnosing it properly. So I think the bottom line is, and I didn't go into all the pros for LPR. I think LPR, well, at least the symptoms exist, right? Patients come to you and have these complaints. Well, those complaints are real. But it may be reflux. It may be reflex. We don't really understand the pathophysiology completely. And most of that is because the symptoms and signs that we have now taken as to be suggestive of LPR, they are not very specific. And again, we have a very high placebo effect. So we need to listen to those symptoms and look for alternative laryngeal, pharyngeal, or esophageal explanations. And I will also sometimes use PPI empirically when I feel like, well, that's a possibility, but I will discontinue it as soon as possible if it's ineffective, so within a month or two. And there's a lot of effort now being placed on lifestyle modifications and behavioral therapy. So I said, don't kick the ENT off your back. So at UCLA, at least, we've been collaborating in a multidisciplinary environment. We'd like to investigate together and determine if the symptoms are reflex, reflux, or primary laryngeal abnormality. And sometimes you need to look at both ends. You have to look at both a good examination of the larynx and a good examination of the esophagus, and sometimes we end up doing lots and lots of testing. That's okay, but at least we are looking at it in a cohesive manner, and so we're doing this more as a multidisciplinary approach. And that also allows us to compare and discuss findings and decide when something is real and something is not. So there is more to learn about the etiologies of LPR symptoms and how to treat them, and there's more to be done. Thank you.